I'll record it. The way you tell if you have any missing assignments is if you look in your grade book and you see a dash, that means that you haven't submitted an assignment. If you see a grade, then I have graded it. If you see an icon, then it's been submitted and I haven't graded it yet. Unless, of course, you submit it via email. In which case, make sure that I know that you've done that, because occasionally I'll miss it. Pardon?
I did that.
Did you do that with last week's assignment finally?
Yeah,
You're able to get it in?
finally got it.
Okay, great. Because I've been busy all afternoon and haven't been able to look at the
Oh, that's
emails.
okay. I did it a couple days ago. Like Saturday night or Friday.
Okay. Really? Let's see. So Felicia, can you hear me now? Because the microphone is apparently working. All right, I'm not getting any response. The question would be, do you have your speakers on? And then that's the only thing I can think of, because this speaker is working. My device is showing that it's working perfectly well. Okay. She still can't hear me. Well, I don't know what to do about that. Because, as I said,
Nikki said she won't be here either.
okay. All right, well, then we'll just have to go on. What I really want to do is some review about what will be on the final. And we'll do that fairly quickly. And there is a discussion this week as well. So I want if we are done with the material that we need to cover for this week, then we'll go offline and people can work on catching up on assignments. Okay. Let's take a quick look. Okay. Maybe do a couple of quick reviews of conversions. Now remember, you can use your notes and the handouts I've given you for the final. We'll take the final in class on Wednesday night. Okay. And we'll have, what I will also be doing is on Wednesday, I will open up the daily checkpoints for the rest of the week, and you can simply get them done and perhaps have a few days when you don't have to worry about school before you start next mod. When we're talking about when we're doing the final, it will be structured the same way the other quizzes have been. which is that you'll have groups of questions and you'll pick some and you'll be randomly given some to do. Right? That's the way that you've seen them so far, or were you enabled to pick them yourselves? Okay. You'll be given random questions. You'll be given a set of questions out of a question bank. I can't tell you what you will have. For the simple reason that it's randomly distributed. And so so you need to be fairly well prepared to take this test. Now, we do not have a text except the online text. You'll have only class time on Wednesday to do the final. So while I'm not going to say you cannot use your text to help with some of the answers, don't get too caught up with that and don't finish the exam, because at the end of the class, the exam's done. Okay? So everyone also needs to be here. All right? Now, once again, we have a couple of certificates to hand out. Bella, in recognition of finishing your second year of classes. And Larissa, same thing, second year of classes. And Michael.
Me.
Yeah. Yeah, it's a bill.
It better not be, but that's what the full rate is for. It should be.
Anyway, we like to recognize when people have reached those milestones in their career here, because we like you to get through your program, get out there and get a job. Start being able to live the life you want to, and on top of that, be able to pay back your loan. And you all know about that. Okay, so let's just do another couple of examples of how we do conversions. As I said, you can use the handouts I've given you. You will be doing these conversions a lot during your study of especially the pharmacy sequence. And I know most of you, I think all of you, are in Pharm 208 next mod. So you'll be doing some math. And it's all based on two things: fractions and ratio and proportion. Ratio and proportion are just a different way of expressing fractions. So don't be confused about the terminology.
Amber says she can't hear or see anything.
All right. I don't know why people can't hear, because the microphone is working according, well, let's unmute it and see if that helps. You may have to let them know that they may have to watch the recording if they can't hear. But I'm going to actually switch on the video so that this can be recorded. Oh, come on. So that we can see, so I can write on the board here. She can. Well, maybe that's what I needed to do then.
I thought Amber said you might have to watch the video. I'm not sure why you can't see her.
I can hear you now.
You can hear now. Good.
Yeah.
Let's see. Let's see. Let's see if I can get this. All right. Let's record this. All right, I'm going to write a few things on the board, again, to review quickly conversions, because you're going to see these. Remember a couple of our conversions. Let's just take a look at as a couple of examples. We want to know how many milliliters are in an ounce. Okay. If I could write, it'd be better. Okay. Now remember, in the conversion rubric for the household sequence, we had the ounce, which is an OZ, and we had the tablespoon, or TSP, TBSP, and the teaspoon, or TSP, and then to the milliliters. Now, there are, in many cases, especially when we're going across systems, there are approximate conversions, and then there are exact conversions. You can use either one. From a practical standpoint, the approximate conversions are accepted as being worthwhile. When doing conversions and calculations, especially of doses of drugs, the standard in medicine is that if we can get within 10% of the actual prescribed dose, we're fine. Now, nobody wants to push that 10% barrier. And in fact, in the compounding pharmacy, which is where you see this more than almost anything else, the bias is less than 1% off. That's what they want. But there are times when that's difficult. So a small error that comes from an approximate calculation is acceptable. And we use a lot of those. This 5 milliliters per teaspoonful is approximate because it's really 4.8. It's actually 4.8 and a little bit more. So when we say that there are 2.2 pounds per kilogram, that's rounded off, but it's close enough. So that will work. Exact calculations will also work. Your test may, if you use an exact calculation, an exact conversion rate, your test may give you a wrong answer. I'll fix that because I will accept it. But note that you can do all of these things with the approximates as well. All right. So we want to know how many milliliters are in an ounce. So what we have is, remember, if we're going from right to left, we right. And if we're going left to right, we multiply. In this case, we're going from left to right. So we're going to multiply. Now, what do we multiply by? Well, we've got 1 ounce which is composed of 2 tablespoons. So what we have is 1 ounce times 2 tablespoons per ounce times 3 teaspoons per tablespoon times 5 milliliters per teaspoon. So let's erase this line. So we've set it up as a bunch of fractions. And we're multiplying by the factors over the arrow. So now we just go through and we start eliminating things that appear in both the numerators and the denominators. So we eliminate teaspoons, we eliminate tablespoons, we eliminate ounces, and we get 1 times 2 times 3 times 5 milliliters. Right? So 2 times 3 is 6 times 5 is 30. 30 milliliters. Okay. So that's not hard. I deliberately chose something that had lots of terms because it doesn't matter if you have 1 term or 15. You just carry out this process and the conversion occurs. If you use the exact, now the thing is that within a system like the household system, there are exactly 3 teaspoons per tablespoon, exactly 2 tablespoons per ounce, right? But across systems, that's where our approximations come in. So it doesn't matter to me if you use 5 or 4.8. The difference is pretty small, right? Way less than 10%. All right? So that's one way of doing it. It's probably the easiest way of setting up and making certain. If you do it this way, where we're taking out all of these, then we know we're going to get the right answer. If there is something that doesn't belong there that you can't cancel out, you set it up wrong. So go back and look at it. See how you can change that and set it up correctly. Questions? Okay. In terms of, we haven't gotten into actual dosing calculations in this class. That's going to be covered someplace else. But this process is important. Why is that? Well, let's ask ourselves a couple of questions. Let us say that you are given a prescription, and the prescription is for 20 micrograms of levothyroxine. Okay. Thyroid hormone. Right. Levothyroxine is currently in the United States the most prescribed drug. More prescriptions are written for this than anything else. So you will see this if you work in the pharmacy. All right. So let's just take a look and look at a label on a jar of drug. And what you may find is that the label is levothyroxine. tablets. 0.02 milligrams. Okay. So we have milligrams and micrograms that we have to deal with. In order to do this properly, we have to use exactly the same units, which means we have to convert now either milligrams to micrograms or micrograms to milligrams. Now, I generally recommend that you convert to the smaller unit. Why? Because you're multiplying. And speaking from experience, including my own, most of us multiply better than we divide. Just a practical reason. I don't care what you do to solve a problem. What I do care about is that you get the right answer. What I recommend is that if you decide to use one method or the other, convert to the smallest, convert to the largest, do that always. Because it's when we start mixing and matching that we make mistakes. So pick a method and do it. The right answer is going to be a number of tablets. So you don't care whether you're converting the dose prescribed to milligrams or the dose in the tablet to micrograms. But let's look at it. Remember that the scale was grams to milligrams to micrograms, okay? And remember that in the pharmacy, micro is always abbreviated MC, okay? That's because in the rest of science, I mean all of the rest of science, the micro abbreviation is the Greek letter mu. It looks like a reverse U with a long tail. The problem is that this can easily be mistaken for II, Roman numeral 2. We never use mu in medicine. You will see it in some textbooks. It's wrong. Okay, so in each case, remember, what's the conversion factor? Anybody remember? Look it up. There you go.
Grams, milligrams, 65.
No, that's grains.
Oh, grams, okay.
Remember, GR is grain. That's another reason we don't like the apothecary. That is a source of confusion.
I don't see that on
Okay. Everybody has a copy of the conversion rubric that I gave you the first day of class. Or maybe the second day of class. And Amber and Felicia, you can speak up if someone else isn't answering. Ah, looks like Alicia has found hers.
Grams, 100 or 1,000 for both, and then the micro is another 1,000.
Okay. Right. So there are 1,000 milligrams in a gram, and there are 1,000 micrograms in a milligram. So if we want to convert milligrams to micrograms, again, we're now going larger to smaller, so we multiply by 1,000. So we've got 0.02 milligrams over, we'll set this up as a little equation, over X, we don't know how many micrograms yet, right? Equals 1 milligram per 1,000 micrograms. Our first chore is to cross multiply, right? So we've got 0.02 milligrams times 1,000 micrograms equals 1 milligram times X. So what's the next thing we do?
Take milligram off each side.
Right, we divide both sides by 1 milligram. So now we've got, so if we do that, 1 milligram and 1 milligram, then those cancel out, right? Those cancel out. And we have 0.02 times 1,000 micrograms equals X. 0.02 times 1,000 is 20. Use your calculator. Don't hesitate. In this class, use your calculator because you'll always have a calculator wherever you're working. And we'd rather you use a calculator and then, of course, check your work, but use a calculator and get the right answer than just sort of guess or make a mistake. Decimal point errors are the most common calculation errors in pharmacy. That's why I want you to use calculators. Okay? So this is 20 micrograms. That's what X is. And that's what we started off with. But when we're doing calculations, we have to make sure that we make those conversions. We can only have one mass unit, whether it's grams, milligrams, or micrograms in an equation. So we are going to see many instances where we have to convert maybe micrograms to milligrams or vice versa, or maybe grams to milligrams. A lot of times you'll see drugs with a dose of half a gram, 0.5 grams, 0.5 grams. And then you'll look on the shelf and you'll see 250 milligram tablets. Well, we can't have grams and milligrams in the same equation because they will not cancel out. So we have to do those conversions. Conversions, one of the first things you want to do when you have a calculation of a dose is ask yourself, do I have to do any conversions? And the answer very often is going to be yes. And when you get into more complicated doses, like calculating IV infusion rates, you may have to do 3 or 4. So conversions are the rule rather than the exception in the pharmacy. So that's why I want you to look at these. And you may even want to make little flashcards, bless you, make little flashcards for yourselves about these conversions. So that you can, part of the value of flashcards, and you know this from having made flashcards in other classes, is that when you have to write it down and think about it, you're more likely to remember it and how to use it. On your flashcards, you may actually want to put an example conversion just to remind yourselves, because you're going to do this for the next couple of months. I promise you. So, questions? More examples? More examples. Got it.
Can you do some examples that are not like straightforward, like how it's 1,000 into 1 milligram or whatever?
Sure,
Then can you do like 250 or whatever?
sure.
They're harder.
Yep. we'll
Because
do
that really threw me off when we had to do that on like the quizzes and stuff. I was like, wait, now I don't know what I'm doing.
Okay. Let's look at where you might see this, and I'll use an unusual number. All right. Let's use let's look at a prescription that comes to you, amoxicillin, 125 milligrams, PO, TID, 10 days. Okay. That's how it might look. And the handwriting might not even be as good as mine, right? Keep that in mind. So what we have here is a dose that is undoubtedly a pediatric dose, because adults are going to get anywhere from 250 to 500 milligrams a dose. Okay. So we know two things. We know that this is probably going to be a liquid, because infants can't swallow tablets or capsules. All right. So we know this is going to be a liquid dose. So we have to calculate a liquid amount for the parent or guardian or whoever to give to this baby. Okay. So we look on the shelf, and what we find is actually a bottle of powder amoxicillin with instructions for how much distilled water to mix into it. Okay. And what that is, okay, so the amoxicillin will be at a concentration, after we mix it, of 250 milligrams per milliliter. Okay. In other words, every milliliter will have 250 milligrams of drug. So how do we make these conversions? I'm going to do it this way, then I'll go to one where you have a little more, another difference as well. So we'll do this. So what we want is, we want to know how much of this drug to give to a patient in each dose. Okay. So we have a dose, let's write this down. We have a dose of 125 milligrams per dose. Okay. And we want to know how many milliliters are going to go into that. We know that we have 250 milligrams per milliliter because we followed the directions for mixing it. Okay. So actually now we set up our equation such that 125 milligrams is our X, right? So again, let's cross multiply. We've got 125 milligrams times milliliter equals 250 milligrams times X. So now we divide by 250 milligrams. Canceling out the milligrams, and on one side the 250. So now we're dividing. We've got 125 milliliters over 250 is equal to X. So what is 125 divided by 250? Thank you. Yes. So 0.5 milliliters equals X. And remember, we always have a leading zero. Okay. So that's nice. .5 milliliters. How much is that? It's a small amount. Okay. So now we have 0.5 milliliters is our dose. We don't dose by milliliters for the most part in this country. We're moving that way. So we dose by teaspoons. So we want to know 0.5 milliliters, and we know that 5 milliliters is 1 teaspoon. So we have an X there. We solve this equation. Okay. And we come up with 0.1 teaspoon equals X. And I'll let you do the math if you want, but that's what it turns out to be. Now, that's not much. So we give people a dosing device that allows them to give that small, usually an oral syringe that's graduated, that we can allow them to use for dosing. Right. Let's make this a little more complicated, just because I like to make things more complicated. All right. Let's say that instead of 250 milligrams per milliliter, it's really 250 milligrams per 5 milliliters. Okay. So let's go through that calculation. We go down here and start. We still have the same dose, but this is going to be 5 milliliters here, right? So we set this up, multiply, again, cross multiplying, and we have 5 milliliters over on this side. Okay. I'm going to erase this last one. And we have to plug in the 5 milliliters over here times 5 milliliters. Now we have a different calculation. We have to multiply this out, right? Okay. So 5 times 125 is 625. Okay. So we got 625 milliliters divided by 250 equals X. What's 250 divided into 625? 2.5 milliliters, yes. So that becomes 2.5 milliliters. And again, we need to convert that to teaspoons. So we have the same conversion factor, 5 milliliters per teaspoon is 2.5 over X. Solving that, what we get is X equals 0.5 teaspoon. And I urge you to do the math, but that's the way it's going to turn out. Right? Now, we do not tell people to go home and go get a teaspoon out of the kitchen drawer because they're not accurate. We can have them get a cooking set of teaspoons, which have tablespoon, teaspoon, half teaspoon, and so forth. But we prefer to give dosing devices, either the oral syringe or the little cup, or the little hollow handled spoons. We do that. So that's another way these things can be handled. These conversions are straightforward as long as we remember what the conversion factors are, which is why you have that rubric. All of those factors are there. Right? Let's do a different example. Everybody happy with this? Okay. There are drugs that are given in fairly large. Yeah, go ahead. There are drugs that are given in what sound like fairly large amounts. Okay, it's not unusual to have an antibiotic like ticarcillin to have a 1 gram dose given by mouth 3 times a day for 10 days to treat certain kinds of infections. If we look on the shelf, what we have is ticarcillin capsules, 500 milligrams. So we have to calculate our dose. But again, we've got grams. And we have milligrams, so we have to convert. I will use my standard, which is to convert to the smaller unit. Now remember, we just went through this. Grams to milligrams is a factor of 1,000. We're converting grams to milligrams, so we multiply. Okay? So we've got 1 gram over X equals 1,000 milligrams over 1 gram. Again, we cross multiply. Excuse me, I inverted that, excuse me. Now it's pretty obvious that X now is 1,000 milligrams, right? So we convert this, set it up and look at it until you get really comfortable with these conversions. And within the metric system, it's nice because it's pretty even across the board. You have powers of 10. Right? We'll go to a couple of things that aren't so even in a minute. Okay? So we have that. And now we know that we have 1,000 milligrams is equal to 500 milligrams per tablet. by 1,000 milligrams over X. So we want to know how many tablets. Well, the answer is pretty obvious. So don't think we need to go through the math. It's 2 tablets, right? Or 2 capsules rather. So that's how we solve these problems. Right? So let's look at another place where you're going to have to make some conversions. Okay. Many drugs, especially potent drugs and IV drugs, are given based on the weight of the patient. Most of our oral drugs, we do not take into account the weight of the patient unless that patient is outside normal adult size, meaning either a child or a person who is very, very, very large. For the most part, humans come in a range that's pretty compact. We don't have too many people that are nearly 8 feet tall. We don't have too many adults that are only 3 feet tall. Right? So we can actually dose a lot of our drugs sort of what we call a standardized dosing. In other words, even though you would look at 2 people who were very different size and say, well, maybe they should get different amounts of drug. For the most part, for many drugs, that doesn't matter. You can adjust that, and physicians will adjust that. I mean, think about it. If a jockey and a football team, a professional center of a football team, go in at the same time, have the same disease, need the same drug, would they get the same dose? Probably not. But for the most part, we don't have those extremes. However, for a lot of IV drugs, we do adjust dosing based on the size of the patient. In fact, many drugs are given a recommendation for how much drug the patient should get per kilogram of weight per day. But you'll see some occasional things working in a pharmacy where you'll see a drug being given at 5 milligrams per kilogram per minute. What that means is that for every kilogram that the patient weighs, they're going to get 5 milligrams of drug injected into them per minute. So the real key here is how much does the patient weigh? Even preemie, quite frankly, even the smallest preemies that survive are not less than a kilogram. In fact, the smallest ones that I know of that have survived are just over 2 kilograms. So let's just say our patient, we're going to make this a little more complicated. Let's say our patient weighs 156 pounds. Okay. So we want to know how many kilograms does the patient weigh. Now, if you look at your rubric, kilogram to pound is 2.2. Now we're going pounds to kilograms. So what are we going to do? We're going to divide. So what we have, and again, we can set this up. We can either do it that way or we can set it up as an equation. We know we have 156 pounds we have a conversion factor of 2.2 pounds per kilogram. If we set that up as a fractional equation, 156 pounds has to be in the numerator. So the other has to be the unknown, x, which will turn out, of course, to be kilograms. So we do that, we get 156 pounds times kilogram equals 2.2 pounds times x, or 156 pounds over 2.2 pounds times kilogram equals x. Pounds go out. What's 2.2 into 156? Again, calculator time.
That was ahead of me. Pardon? 70?
Okay. I didn't disbelieve you, Alicia. I was waiting for the confirmation because everything should be checked, always. All right. Now, your patients seldom will come out in even numbers of kilograms. But that's okay. Because when we're giving drugs by IV, we adjust the amount by the volume of the drug that's actually injected. Okay? So 70 kilograms. So now we know that we want 5 milligrams times 70 kilograms. Okay? Because it's 5 for every kilogram, right? So we're multiplying that. So now we're going to get 350 milligrams per minute of the drug. We won't go any further with that. But that tells us how much drug this patient's going to get. Okay. Make sense? Okay. Now, length issues rarely come into the pharmacy. But we're going to do one length conversion. The reason that we are is because in the pharmacy, we often are asked to prepare drugs to be given by IV. And there's 2 ways to give drugs by IV. One is an infusion pump, and you've all seen those. They put the bag up, they run a line through the thing, and a little peristaltic valve sits there and pumps the drug in at a defined rate in milliliters per hour. Okay, so that's another conversion you have to do. So because they're not programmed in minutes. So but the thing is, the other way is that we just hang the bag and let gravity do its work. Well, with a pump, it doesn't matter whether that bag is hanging up here or if it's down on the floor. The pump is going to suck stuff out of it until it goes dry. But gravity has to be above. The rule is it has to be 36 inches above the heart. Now, if you're sitting in a chair and you have an IV in your arm, your heart's here, your arm's here. So you need to have whatever distance this is, roughly 8 inches as I'm feeling this measurement, plus 36 to go up. So you need 44 inches of tubing. Okay? But a lot of times we're going to be calculating the tubing in centimeters. Okay, so let's take a look. Again, looking at your rubric, you've got inch to centimeter, 2.54. Don't fall into the trap of estimating it at 2.5. Some people do. It's not a good idea. This is one where we should be more exact. So again, if we want to know how many centimeters is 44 inches, we're going from left to right. Right, so we're going to multiply. Okay. So we've got 44 inches times 2.54 centimeters per inch. Another way of setting it up. Okay. Is going to be whatever that is, calculator time. 111? 111.76. Okay, now, lest we get ourselves too caught up in being too precise, if you were working in the pharmacy, you'd round that off to 112. It's safer to go higher than lower in cases like this, because gravity is important. Why do we hang it that high above? Because gravity is pushing things down, but our arterial and blood pressure is actually trying to push things the other way. So we have to overcome that, and we have to overcome it thoroughly. So we do this. That's a rule of thumb. Is it necessary? What if you only had it 30 inches above the heart? Would that work? Probably. But don't try to get clever. Rule of thumb, 36. Okay, that's the only length conversion we're going to make. The other place you see it, of course, is in baby's birth. You weigh them and you measure their length. And so it's always in inches. So it really, you don't see those conversions. I've never seen a baby measured in centimeters. Okay. All right, let's take, it's 7 o'clock. It's actually 8 minutes after. Let's take a break. And I'm going to pause the recording. Okay. Recording again. Any other conversions you'd like to see? Or have you had enough of those? I'm getting a nod on the enough of those. Okay, that's fair enough. So let's talk about some of the other things we've spoken about today. Some of the issues of this mod. We talked about the hospital pharmacy, which is a little different from the community pharmacy. Excuse me. In the community pharmacy, you deal directly with patients, for the most part. You deal directly with patients, you take in their prescriptions, you fill them, you take their money, you take care of all the housekeeping, you take care of making certain that when drugs get low in stock, the pharmacist authorizes an order to go in. You receive the order, you log it in, QA the order to make sure that you got everything you ordered, or if you didn't, that it's been back ordered. You shelve it, and you just generally do all the chores. If you're working in a Walgreens or King Super, you're also likely to have to be doing some stocking of the OTC materials as well, the other shelves. In the hospital, we don't have the same contact. We have very little, in fact, contact with patients, because the pharmacy is in the service area of the hospital, not in the patient area. There was a time when drugs were stocked on wards and were looked at as being a commodity that nurses and other caregivers on the ward would calculate doses and so forth. This led to a lot of problems. Now we have centralized pharmacy services, and instead of stocking anything other than a few common drugs occasionally on the ward and emergency drugs, because every ward will have its crash cart. You know what a crash cart is. Every ward will have that. So those are stocked and on the ward. But for the most part, all the medications come out of the pharmacy. In the hospital pharmacy, as opposed to the community pharmacy, they prepare a lot of parenteral drugs. As some of you talked about in the sterile processing assignment we had, a lot of them do have their parenteral drugs prepared, and those are all done in a sterile area of the pharmacy in the hospital. So we never see the patient. We have nothing to do with billing. When a doctor submits a medication order, it goes into the patient record, which goes to medical billing. It goes to whoever needs to see it, including the pharmacy. So we do all of that work back in a way that we don't have to deal with patients. So there's a real difference in not just the kind of work that's done, but in the way we actually work in a hospital pharmacy. This is as opposed to, of course, the outpatient pharmacy that most hospitals also have, which is more like a community pharmacy. Sterile processing involves using the right equipment. We talked about laminar flow hoods, which use HEPA filters. And we have a horizontal hood where the HEPA filter is at the top. And we have a vertical hood, a vertical hood where the HEPA filter is at the bottom, because air is being drawn down into the hood. The inspection requirements are a little bit different. Horizontal hoods are inspected at least every 2 years. Vertical hoods are often inspected on a 1-year schedule. And we clean them regularly. Now, we don't put chemicals into a HEPA filter. We clean the rest of the hood. Chemicals will damage HEPA filters. So we don't use that. We don't put them in there. We use these laminar hoods for preparing both sterile products and dangerous drugs. Chemotherapy agents, toxic materials that are used, etc. So we have different purposes. When we're preparing sterile products, every product has an expiration date. Everything that goes into the hospital has an expiration date. But that expiration date is set experimentally. In other words, when a pharmaceutical company manufactures a product, whether it's oral or injectable, every manufacturing run will take a certain percentage of the run and put it aside for testing. And they test quarterly. What they test for quarterly is any change in the product, chemical or physical. Physical changes could be changes in color, or could be the appearance in liquid of solids, precipitates. Okay, so we have these different tests that are done, and they keep testing until either something changes, and that then affects the batch, the product, or until 5 years passes, at which time they stop, because the maximum storage for any pharmaceutical product is 5 years. Do they last longer than that? Oh yeah, many drugs will last for decades without deterioration. However, we don't test past 5 years. So everything comes with maximally a 5-year date. Some products are less. During the development of a drug, not only are they doing clinical trials, but they're developing their manufacturing process. And they are determining the shelf life of their product. So that by the time the drug is approved, they know if it can be on the shelf for 5 years or it has to be less. And it's labeled accordingly. So when we are making products in the hospital, we're actually changing them. And so those expiration dates are no longer valid. Okay? So we have guidelines. If we're doing sterile products, the guidelines are in the United States Pharmacopoeia. And for injectables, for parenteral products, those dates depend on whether there is a high, moderate, or low risk of the product degenerating over a short period of time. Products with a low risk are capable of being stored for 2 days at room temperature. Products with a high risk of deterioration for 24 hours at room temperature. Moderate risk is 30 hours. The refrigerated storage is 10, 14, and I think 21 days for low, medium, and high risk. We can also prepare drugs and freeze them, and we often do. And uniformly, we have what we call a use by date instead of an expiration date. It's called use by, which means that the drug has to be used within that, by the time that that date passes from the time of the preparation, or discarded. Can't be reworked. Use by is distinguished from expiration because it's not experimentally determined. These are guidelines. Some products will last longer. No products should last shorter times than we recommend. These are conservative times. So that if you have a product that has a 24-hour use by date, you not only have to label it and record the day you manufacture, the day you prepare it, but the time you prepare it. Because just because you prepare it at 8 a.m. today doesn't mean that it can last until noon tomorrow, because that's more than 24 hours. So we put a time as well. So these are statutory in that the USP is accepted as the standard for preparation of materials in the United States. There are the equivalents elsewhere as well, and they're all about the same. These are for things that contain water, and water is a very destructive substance. It's also very necessary, but it's also destructive, especially of drugs. So we established this for water. That's for parenteral preparations. there's always a chance of contamination. That's why we want to use them quickly. For non-sterile, like our amoxicillin liquid that we talked about earlier tonight, the use by date is 14 days. That's why your amoxicillin prescription comes with a label that says use by discard after 14 days or use within 14 days, and you're supposed to refrigerate. Okay. If they do not contain water, if it's something like, if you were doing a medicated lip balm, which is something that you will probably prepare in the lab pharmacy class you take, I don't know if that's going to be 208 or 209 here, you'll prepare a lip balm. And lip balms are prepared in a pharmacy. Medicated lip balms are prepared, again, by a procedure, and they're given a 6-month use by date. So it depends on the product as to how soon you have to use it after it's prepared. Now, does chapstick come with an expiration date? I haven't looked lately, but I don't think they do. All righty. Does it have an expiration date on it? Okay. Part of that's because yours does. What does it say?
Mine says 620. And it has a lot number.
Yep. 620. So that means it has to be used by June of 2020. Okay. Products that are manufactured in bulk like that, they have data. When they make enough of these things, they've accumulated the data that they don't have to follow the use by guidelines because they have the experimental information to back up a longer date. Lot numbers allow us to track problems with a drug. Every manufacturer has a lot number for every time they manufacture a batch of drug. And that lot number allows them to go back if there's a problem with the drug, to go back and find out if the problem occurred during the manufacture, and if so, if the problem is related to any of the components that went into the product. Because a drug is an active substance with other materials to carry it, to formulate it, to form tablets with it. Your little bitty tablet of ibuprofen that has 200 milligrams, if you took the ibuprofen out and compressed it into a sphere, it would be smaller than a BB. So what they do is that to make these things usable, they add what we call excipients. Excipients are inert ingredients, starches. Sometimes they'll use silica, sand. They'll use titanium dioxide for colors. Excipients are things that come off a list that we call the generally recognized as safe list of materials that we can put into a drug without having to test for toxicity. These are compounds that have been determined to be safe for human use and have been determined safe for a long time. So what they do is they go back and all of these are bought at pharmaceutical grade by the pharmaceutical companies. And they will look and see if there's a problem with each batch of the excipients to see if there's a problem. Because in the manufacture, they not only set aside samples of the finished product, but all of the components are also samples are set aside for analysis. Now, a lot of times you'll see drug recalls. I'm sure you've seen these happen. Most of them are what we call class 3 drug recalls, meaning there's nothing dangerous that's going to happen. Usually it's some dye that is oxidized when it wasn't supposed to. It changed color, but has no effect on the safety of the drug. And so these class 3 recalls are basically don't sell anymore, but we don't have to get it out of the hands of people. Class 2 recalls are of drugs that the change can cause medically important problems that are resolvable. A class 1 recall usually involves people dying after taking the drug because of something wrong. And class 1 recalls require immediate removal from the market and retrieval from patients who have been prescribed drugs, but it's by lot number. That's why you will see in the on the stock bottles in your pharmacy, you'll actually see the lot number, and that should also go onto the label of your prescription. So that if there's a problem and there has to be a class 1 or 2 recall, they can find out who has gotten these drugs and contact them and get them back. These are always done at the expense of the pharmaceutical company, and in general involve replacement of the drug where appropriate for no charge to the patient. Okay, so we use these dates. So that's something that we do when we're working in sterile compounding. We set these use by dates, and we adhere to them very, very closely. The whole purpose of sterile compounding is protecting the patient. Our first concern is always protecting the patient. So that's why we want people to be able to do their calculations accurately. And we want people to understand that when they're working with patients and working with drugs, we're careful. You don't drop it on the floor and say, oh, the 3-second rule applies, pick it up. Okay. There's actually conflicting data as to whether or not the 3-second rule works. A number of years ago, a high school student in, I think, LA, actually did a study where she went into a hospital and dropped things on the floor and then picked them up carefully, put them into sterile packaging, and then took them home and did microbiological analysis on them. And she found that even in a hospital, which is a dirty place, I mean, people get sick in hospitals, she couldn't grow anything. She couldn't culture any bacteria or anything else off these things. There have been other, she actually got a prize for that study. The other, on the other side, though, there have been some other studies that have disputed that. But we're conservative when it comes to our patient safety. And so if it drops on the counter, if it drops on the floor, it goes in the trash. Now, does that stop patients from dropping things on the floor, picking it up and swallowing them? No. But at least when they go out of the pharmacy, we know they're safe as any drug can be. Okay. So we follow, we have in the pharmacy, we have special trays that we count drugs on. And we keep those things clean at all times. We clean them off between prescriptions. I've been told that some pharmacies don't do that. That's not correct. It's a violation of standard procedures. So what we want to do is look at what we're doing in terms of, always in terms of patient safety. We haven't talked a lot about community pharmacy. I think that's going to come up in another class. You'll study that. But we've looked at a number of things. So questions about any of the chapters that we've studied, any things on the exams that didn't make sense to you? I know I went through and corrected a lot of your assessments because sometimes the answers were graded wrong when they weren't. So a number of you probably saw your grade go up. Same thing will happen on the final. I will look through everything. We talked about documentation. You're going to study a lot of documentation. You probably already have studied some medical records and documentation classes. But documentation is important. It's one of the things that hospitals are judged on, is the quality of their documentation. And we talked about HIPAA. You've all heard probably as much as you ever think you want to hear about HIPAA. But when you were doing your discussion last week, no two people chose the same incident because there are so many violations of HIPAA. I hope that one of the things that you picked up from seeing all of these different HIPAA violations was the need for continual training and reminders that these violations are taken very seriously and they can be punished by a number of things. Fines is one, loss of licensure or job is another. There's even been a couple of times when people have gotten some jail sentences for violations of HIPAA. And it just astounds me, as I said in one of my comments, that it appears that many of these things are knowing. They know they are not doing the right thing, but they do it anyway. So this is where constant reminders, first off, if you're so bored you have time to go looking through records, snooping through records, then something's wrong with the way you're working. That's one thing. But another is it's just totally unethical. And that's one of the reasons that we touch on ethics in a lot of our classes as well, because we have to be seen as trustworthy as well. And one of the things that we have access to legally is information about people's medical history and their medications. And we don't want to think that we have to worry about the person behind the counter. So you saw that documentation is everything. When we're working in a compounding facility as a pharmacy, and we are preparing drugs, and we do a lot of things. We will prepare drugs on physician orders that don't exist in the pharmaceutical catalogs for several reasons. Sometimes patients are allergic to some of these excipients, and we have to formulate special forms for those patients. Sometimes doctors want very specific mixtures of drugs for various purposes. And so they'll ask the compounder to take care of that. Other times, we'll be preparing pediatric doses. Children and the elderly metabolize drugs differently. You know, children are not just little adults. Their livers are not are in some ways more efficient because they haven't been beaten up by all the poisons that we give ourselves all the time. And our lifestyles change the way we metabolize drugs. One of the reasons doctors want to know if you drink or smoke and how much is that alcohol and tobacco change liver function. And livers are the main detoxifying organs of the body. Alcohol also messes up your kidneys. So it's changed the way you excrete liquids. And most drugs that we take are excreted through the kidney. So we, especially with children, as I say, they're small, therefore the doses are smaller, but there are many drugs that are not put into a form that's easy to give to children. Things like amoxicillin are, because children take them all the time. But there are many drugs that are not in a form, and then pharmacists will have to prepare them. Hospitals do this a lot. There are actually specially trained people that work with the NICU in a big hospital for preparing those drugs. And they have special formulations ready to go. So there's a lot that goes on that we have to think about. But whenever we do any compounding, we keep very careful records of everything that goes in, a compounding record. Or, as some people might call it, a mixing record. But it's a list of everything, including batch numbers or lot numbers, and expiration dates, manufacturer, etc. We keep all those records. Then, when the records go into the patient record, what goes in is a reference to the compounding record that we use. And the compounding records are stored, they're kept. We also need to be careful about computer security. One of the posts about HIPAA violation was a computer that was stolen from a pharmacy. And that computer had patient records on it. I mean, it wasn't like an Equifax hack, but nonetheless, that's important information to guard. So computer security is another one. Not just keeping people from hacking into your system, but making it impossible for people to steal your equipment. So generally speaking, pharmacies won't use the cheapest computers. So they will have more expensive systems. These are more attractive to thieves, the thieves that want these things. So we have that as well. I personally, we look at new computing technology, and cloud storage is all the rage now. I don't use the cloud. I'm not sure that I trust it yet. I'm told by my computer nerd friends that it's perfectly safe. And my response is, maybe from you, but whatever one person can program, another person can hack into. So, it's one thing to have your email Christmas letter hacked by people that you don't want to read it. Who cares? I mean, it's another thing for people to get into your bank records. So that's one of the things that we have. The computer technology chapter in your text is, you probably all laughed at parts of it because it's out of date. I mean, nobody uses PDAs anymore. So those that actually had the PDA questions thrown at them on the assessment, I just gave you credit for whatever answer you put down because they're not used. We are moving, however, to smartphone applications. Almost everything that is that can be stored on a computer file can now be found using a smartphone application. There are smartphone applications for records. Just love it when that happens. As I told you, my wife was a home health PT, and their paperwork was pretty daunting. Well, there are smartphone applications of that paperwork, and laptop applications. But nonetheless, and it's all transferred back to the home office through the internet. So, so we have things changing quite a bit. Computer technology, this book obviously was written for people who have never seen a computer. So don't worry about some things that are totally out of date at this point. So anyway, my voice is about to give out, so I'm going to quit unless anyone has questions. If you have questions, ask. I'll answer them. Okay. Once again, I want everyone to look at their grade book and find out what they need to turn in. Now, I will say, most of you, that's going to be nothing at this point, and that's fine. But others do have some gaps in their grading. If you see a 0, that means that I have had to put a 0 in because we're past the time it was due. And that's what we have to do. That doesn't mean that you can't get any credit for that assignment if you do it. You just won't necessarily get full credit. But some credit is better than 0. Okay? And most of you guys have pretty good GPAs I know you want to keep up. So don't let yourself get behind. Okay. All right. For those of you who are online now, I have 3 names. That's all that's here. You guys don't have to do this, but anyone who isn't here and who actually sees this video, I want you to send me an email with the word MEDAN, MEDAN, in the email to let me know that you've watched this. And so now I'm going to turn off the recording, and people here in class will start catching up on anything they have yet to do or studying for the final.